Okay, so I'm Brandy for any new faces in the crowd, and today I'm going to be giving the CE presentation over managing triple therapy and acute coronary syndrome. So I have no conflicts of interest or financial disclosures to verbalize this time. And at the end of this presentation, the learner should be able to describe the different medications used for dual antiplatelet therapy and anticoagulation, identify various indications for triple therapy, analyze available literature regarding the use of dual antiplatelet therapy and anticoagulation, determine an appropriate strategy for triple therapy de-escalation, and discuss appropriate antithrombotic regimens in patient-specific scenarios. Here are some abbreviations that you may see throughout the presentation. And so first, I'll just start with what is triple therapy. And so triple therapy is the concurrent use of dual antiplatelet therapy and an oral anticoagulant. And so in the human body, we have blood moving through our circulation with high shear flow and low shear flow. Shear flow is just flow induced by force. And so structurally, the thrombi that can occur under these two different types of flow are distinct. And I think that this figure from the European Heart Journal does a really good job of highlighting the major differences between arterial and venous thrombosis. So on the left, we can see the high shear flow, such as arteries, and the arterial thrombi are rich in platelets, and they can form at the sides around a ruptured atherosclerotic plaque. And so arterial thrombosis can be the cause of MI, while venous thrombosis leads to VTE and PEs, and this can happen in places of low shear flow, such as the veins. And these venous thrombi are rich in fibrin, so we would want to target the extrinsic or intrinsic pathways of anticoagulation and the red blood cells that the thrombi can occur actually in despite of an intact endothelial wall. And so I think when you think about the mechanism of action of each of these different clotting mechanisms, it makes sense about the medications that we would use to treat each of these different scenarios. And so why do we care about triple therapy and ACS? So stent thrombosis occurs at a rate of 0.1 to 0.4% per year with an associated mortality rate of up to 45%. So that's not small. It's estimated that about 10% of the nearly 1 million patients undergoing PCI in the US each year have an indication for chronic oral anticoagulation. So patients with ACS, it's thought that the incidence of AFib ranges from 10 to 21% in that patient population. And so those patients would obviously have an indication for triple therapy at some point, but the annual risk of a major bleed on triple therapy is up to 12%. So first, let's talk a little bit about dual antiplatelet therapy. So of course, we all know that the purpose of dual antiplatelet therapy is to prevent stent thrombosis. Stent thrombosis is an abrupt thrombotic occlusion of the stent, and the greatest risk of a stent thrombosis is within the first 4 to 6 weeks after stent placement. There is also restenosis, which is not acute, but that is rather a gradual re-narrowing of the stent over time. And the most common widely accepted mechanism is, you can see in the left-hand side, the top left corner, it is due to impaired re-endothelialization. And so that's just the risk of stent thrombosis that is seen with delayed re-endothelialization due to the anti-proliferative effect of the drugs that are released by the drug-eluting stent that are intended to prevent the hyperplasia. And so that's either unintentionally delayed or it impairs the mitosis required to restore the natural barrier between that foreign stent and then the intravascular cells. There are some other mechanisms as well, such as hypersensitivity reactions. So that's localized reaction to the stent itself. You can also see neoatherosclerosis, which is just a new plaque generation. So that would be considered a stent failure. And then either malpositioning of the stent or stent dismantling, which just has to do with the struts of the actual stent itself, either causing either fracturing or there being kind of a gap and it not being able to adhere to that vascular wall. And so the antiplatelets that we use are aspirin plus clopidogrel or prasugrel or ticagrelor. to help prevent stent restenosis. And so just quickly to review the mechanism of action of these medications, aspirin is the foundation of our antiplatelets. It is an irreversible inhibitor of the COX-1 and 2 enzymes, and COX-1 is involved with the ring closure and the addition of oxygen to arachidonic acid, converting it to the prostaglandins. And so what this does is it leads to an increase in production of prostaglandins, such as thromboxane A2. And thromboxane A2 is produced by activated platelets during hemostasis and has prothrombotic properties. So it stimulates activation of new platelets as well as increases platelet aggregation. And so by using aspirin to inhibit COX-1, we can actually decrease platelet activation and aggregation. So dosing for ACS involves the 325 milligram dose. That's generally the first dose, loading dose given either at home or when the patient arrives to the emergency department. And then the patient will be continued on a low dose aspirin, potentially for life. We most commonly see 81 milligrams used here in the United States. And so our other antiplatelets belong to the class of medications called thienopyridines, or the P2Y12 inhibitors. So the P2Y12 receptor on platelets is activated through the binding of ADP, which then activates the G protein pathway. There are a few mechanisms by which the activation of the P2Y12 receptor causes platelet aggregation, but for the sake of time, I'm not going to go through all of that. What's important to note is that the end result is the activation of a P2Y12, which alters the ligand binding properties of the glycoprotein receptor. And so inhibition of the P2Y12 receptor thereby suppresses platelet activation. And so when you look at the top here, you can see clopidogrel and prasugrel are our oral prodrugs, which requiring hepatic metabolism to generate an active metabolite that irreversibly inhibits the P2Y12 receptor. Ticagrelor is a direct acting, which means there is no metabolism required, and it reversibly inhibits the P2Y12 receptor. And of course, cangrelor is our IV option that can reversibly inhibit the P2Y12 receptor. And so here is just a nice little summary chart of some things I've already mentioned, and then the major trials that involve dual antiplatelet therapy with these agents and ACS events. So I'll start with clopidogrel. In the 2001 CURE trial, clopidogrel reduced the combined endpoint of death, MI, stroke, and reinfarction in combination with aspirin in patients with ACS and in STEMI. And those patients were on DAPT for 3 to 12 months. Prasugrel in the TRITON-TIMI 38 trial, patients with ACS with a scheduled PCI, prasugrel was associated with significantly reduced rates of ischemic events, but with an increased risk of major bleeding when it was compared to clopidogrel. More recently, in September of 2019, the ISAR REACT 5 trial, in which prasugrel patients had a significantly lower incidence of death, MI, or stroke as compared to ticagrelor, and they did not notice a significantly different incidence of major bleeding in that trial. And lastly, ticagrelor. In the PLATO trial, patients with ACS significantly reduced the rate of death from vascular causes, MI, or stroke, but there was an increase in non-procedure related bleeding as compared to clopidogrel. There was also the Pegasus-TIMI 54 trial, in which they found patients with the MI between 1 to 3 years previously. Treatment with ticagrelor significantly reduced the risk of cardiovascular death, MI, or stroke. However, they did notice an increased risk of major bleed. And one thing I did not previously mention about ticagrelor is that it is, we have to worry about those strong CYP3A4 interactions and the serum concentrations, particularly inducers that can increase the already, I guess, major bleeding risk of ticagrelor. Those effects can also be increased. So just use caution when looking at those drug interactions. And so that brings us to the 2016 ACHA guideline focus update on the duration of DAPT in patients with CAD. So these guidelines lean toward the recommendation of 1 year of DAPT therapy when a patient is post-ACS event with stent placement. They do have a class 2B recommendation of discontinuing therapy after 6 months if the patient is a high bleed risk, or continuation for longer than 12 months if the patient is at no significant overt risk of bleeding. And that's for patients with a recent ACS event. The guidelines also offer recommendations for patients who are electively being treated with stable ischemic heart disease. And so if they have a bare metal stent placed, at least 1 month of dual antiplatelet therapy, because we're not worried about that impaired re-endothelialization that we had discussed earlier. If they have a drug-eluting stent placed, at least 6 months of DAPT is recommended. And post-CABG, there is a class 2B recommendation for 12 months with clopidogrel. And so one of the little tools in the tool belt is the precise DAPT score. This was developed to predict the risk of bleeding in patients treated with dual antiplatelet therapy. And the score was developed from the data of from 8 randomized clinical trials and the 2017 European Society of Cardiology focused update on dual antiplatelet therapy and CAD. Gives a class 2B recommendation for using this scoring system to decide on shortening duration of DAPT versus doing the standard 1 year. The 2016 ACHA guidelines mention the DAPT score, but that scoring system is concerning like prolonging antiplatelets beyond 1 year. So these are just a couple of tools if you're trying to decide, is this patient appropriate for shorter dual antiplatelet therapy or longer? That could be a tool in your tool belt. And this is just an example from the precisedaptscore.com. You can look these up and play around with them with any of your patients. And so in summary, the 2016 ACCHA DAPT recommendations: after a drug-eluting stent, DAPT should be continued for 6 to 12 months. 12 months after ACS event, 6 months for an elective stable CAD. But overall, all of these should be case-by-case basis, and an assessment of the benefit versus risk of ischemic event versus bleeding. And patients tend to have lots of opinions about things like this, so always make sure to get their input, and of course, the clinical judgment of the treating physician. And so moving on to anticoagulation. Warfarin, our OG anticoagulant, is a vitamin K antagonist, inhibits clotting factors 7, 9, 10, and 2. And also can inhibit the natural anticoagulants protein CNS. Pretty much any indication for anticoagulation is indicated for. We have to monitor INR. It is maintained at 2 to 3 for most indications. However, now most guidelines favor DOACs over warfarin due to the reduction in risk of intracranial hemorrhage and reduced monitoring requirements. However, it does still remain the anticoagulation of choice in mechanical valves or patients who have contraindications to DOACs or coagulation deficiencies. So here's a table of our 3 most commonly used DOAC. So dabigatran is the direct factor 2 or thrombin inhibitor, and the 2009 RELY trial looked at dabigatran administered at a dose of 150 milligrams twice a day in AFib patients as compared with warfarin, was associated with lower rates of stroke and systemic embolism, but similar rates of major hemorrhage. So no real benefit, like pro to choosing one over the other in regards to bleeding. Rivaroxaban is one of our direct acting factor 10A inhibitors. It is indicated to reduce the risk of stroke in AFib and for the treatment of VTE. And the 2011 ROCKET-AF AFib patients looked at AFib patients, and it was found to be non-inferior to warfarin for prevention of stroke or systemic embolism. They also noted that intracranial and fatal bleeding occurred less frequently in the rivaroxaban group. And lastly, we have apixaban, which is also another direct acting factor 10A inhibitor, and that the Aristotle trial looked at patients with AFib, and it was determined that apixaban was actually superior to warfarin in preventing stroke or systemic embolism and caused less bleeding and lower mortality. So sometimes why it's my favorite DOAC. And then dosing is there for completeness sake. And of course, the purpose of anticoagulation in AFib is prevention of ischemic stroke, and the 2019 ACC-AHA focused update recommended that for patients with a CHA2DS2-VASc of greater than or equal to 2 in men, greater than or equal to 2 in 3 in women, oral anticoagulants are recommended, and guidelines recommend DOACs over warfarin in DOAC eligible patients with AFib. So that leads us into our first patient case. So PK is a patient that is admitted to academic medicine, and unfortunately, yesterday he had a heart attack. He's a 66-year-old male, rushed by ambulance to the hospital. He underwent PCI with placement of a drug-eluting stent to the right coronary artery. He had aspirin 325 at home, was loaded with clopidogrel, and received a heparin drip until his cath. And so thankfully he's doing okay today. So let's learn a little bit more about him. So past medical history, significant for AFib, hypertension, type 2 diabetes, heart failure, OSA. So off the bat, we know his CHA2DS2-VASc is greater than 2. Home medications, pertinent for warfarin, labs and vitals, pretty unremarkable. So what antithrombotic drug classes do we want to ensure this patient is on now? Well, of course, he needs anticoagulation, right? He has AFib. So warfarin or DOAC. He also needs dual antiplatelet therapy because he just had a heart attack and has a stent. So he needs aspirin and a P2Y12 inhibitor. So this situation presents a classic clinical conundrum, as both dual antiplatelet therapy and oral anticoagulation are indicated for patients such as this. It leaves us with this scale where we have to balance 2 different risks, combining the pharmacologic effects of DAPT and oral anticoagulation. And it leaves patients with a substantial risk of bleeding, which has to be carefully balanced with the increased risk of thrombosis from AFib, stent thrombosis, and future major adverse cardiovascular events. So now that we've reviewed all of antiplatelets and anticoagulants, let's shift to what the guidelines say about what we should do when we're in situations where both are perhaps warranted. There are multiple guidelines that we can look at to give us guidance concerning what to do in these situations. And so I'm going to break down those guidelines here, and then we'll break down some primary literature for our newest guideline. So the 2014 AHA-ACC guidelines for the management of patients with NSTEMI state that duration of triple therapy should be minimized to the extent possible to limit the risk of bleeding. They also recommend proton pump inhibitors for patients with a history of GI bleeding, and also may be reasonable in patients without a known history of a GI bleed if they're perceived to be high risk. And then targeting an INR of 2 to 2.5 may be reasonable for warfarin patients. The 2016 ACC-AHA guideline focused update of those 2014 recommendations. This is one of the tables that they mention in that focus update. And so they give some guidance, but not a lot of specifics on how to manage these patients. So basically they say, assess ischemic and bleeding risk, keep triple therapy duration as short as possible, target a lower INR of 2 to 2.5. They mentioned that clopidogrel is the P2Y12 inhibitor of choice, use low dose aspirin, and again, PPIs. And this is the American College of Chest Physicians, and they released updated guidelines in 2018. And concerning triple therapy, they divided their recommendations into 2 different situations. The first one being AFib patients undergoing elective coronary stent. These guidelines state that if the patient is of low bleeding risk, these patients should be treated with triple therapy for 1 to 3 months, and then followed by anticoagulation plus clopidogrel for 12 months. So drop the aspirin. Then once your 12 months is complete, anticoag alone. Patients with a high bleeding risk, shorten that triple therapy back to 1 month. Shorten your anticoagulation plus clopidogrel single antiplatelet therapy back to 6 months, and then move on with anticoag monotherapy. That's for elective. The other situation the guidelines address is for patients undergoing coronary stent in the event of an ACS. The guidelines state that these patients, if they are low bleeding risk, based off their Has blood score, they should be treated with triple therapy for 6 months, followed by anticoagulation, plus clopidogrel for 12 months, followed by anticoag monotherapy. And then the high bleeding risk, you can shorten that 6-month triple therapy period back to 1 to 3 months, but still do anticoagulation and that single antiplatelet therapy agent for up to 12 months, followed by anticoag alone. So the resounding is that once we are out of these pre-specified windows, at some point, patients should be able to go back to anticoagulation monotherapy alone, even if they've had history of an ACS event. The European Society of Cardiology is another one of our guidelines, and they say very similar things to what we've reviewed. So triple therapy with aspirin, clopidogrel, and oral anticoagulation should be considered for 1 month, irrespective of stent type. Consider triple therapy up to 6 months in patients that have a high ischemic risk, in which outweighs their bleeding risk. Dual therapy with clopidogrel and oral anticoagulation should be considered as an alternative to 1 month triple therapy when the bleeding risk outweighs the ischemic risk. They also mentioned rivaroxaban 15 milligrams daily may be used in combination with aspirin and or clopidogrel, and we'll look at that dosing in a trial a little bit later. They do not recommend prasugrel or ticagrelor as part of triple therapy at this time. There's also this 2018 white paper that was published in Circulation AGHP. It is an expert consensus that I will be referring to a little bit later in the slides. And then finally, that leaves us with the most recent guideline that addresses triple therapy. And we're going to stop here and look at some of the primary literature supporting certain recommendations that these guidelines make. So I have 4 questions, basically. Should we triple therapy or dual therapy? How long should we use triple therapy? Which anticoagulation should we use in patients with AFib undergoing PCI? And which P2Y12 inhibitor should be used in a triple therapy situation? So do we dual or do we triple? So the first trial is the WOS trial. So the objective of this trial was to determine the safety and efficacy of clopidogrel alone compared with clopidogrel plus aspirin in patients on oral anticoagulants and undergoing PCI. So this was published in 2013. So DOACs were not as widespread. So this trial did look at warfarin. So patients were randomly assigned to warfarin plus clopidogrel or warfarin plus clopidogrel plus aspirin for triple therapy. All the patients were pre-treated with a maintenance dose of 75 milligrams of clopidogrel per day for at least 5 days, a loading dose and of either 300 or 600 milligrams, depending on when their PCI was. 31% of patients received a bare metal stent, 69% of patients received a drug-eluting stent. And so I think when you look at a study that is focused on what drugs you're taking, it's important to look to see how per protocol the study was. So at 1 year, oral anticoagulation was being used by 92% roughly in each double therapy and triple therapy group. At 1 year, clopidogrel was being used in 80% of patients in the double therapy group and 78% of patients in the triple therapy group. Okay, good to go. At 1 year, aspirin was being used by 66% of patients in the triple therapy group, which is fairly close to the 69% of patients who had a drug-eluting stent randomized to that antiplatelet regimen for 1 year. So the primary endpoint of this trial was the occurrence of any bleeding episode during 1 year of follow-up. The primary endpoint occurred in 19.4% of patients receiving dual therapy and 44.4% of patients receiving triple therapy. It was powered to detect superiority of double therapy. And as we can see in this graph, in the p-value, it was statistically significant. I will note, for all of these trials that we look at, the bleeds are not equal. The WOS trial defined bleeding severity with 2 different methods to categorize bleeding. The first was TIMI and the second was Gusto. I'm not going to go through all of this, but the thing to see from these results is that using TIMI or Gusto, major or severe bleeding was not significantly different, but it leaned towards the triple therapy group. When moderate and minor bleeding were added, that's when we saw the statistically significant greater risk in the triple therapy groups. So this graph shows the secondary composite endpoint. And I will just go ahead and preface that we should interpret these results with caution. So you can see that there is a statistically significant difference in the endpoint. However, this trial was not powered to detect non-inferiority. The component that caused this difference seen in the graph the most was all-cause death, with 7 patients in the dual therapy group and 18 patients in the triple therapy group. And concerning stent thrombosis, there was not a statistically significant difference. So overall, you cannot make the statement that there is no increased risk of thrombotic events because this is a superiority study. And so we cannot be interpreting this as non-inferiority is the bottom line. And so the author's conclusion of this study was treatment with clopidogrel and oral anticoagulation was associated with a significantly lower bleeding risk than triple therapy, with no evidence of increased risk of thrombotic events by holding aspirin. And I've already kind of noted some of the major limitations of this study. This is a triple therapy or triple threat. Some of the other studies that the 2019 ACC AHA update focused on was this 2011 meta-analysis. And so they did note that triple therapy versus double therapy was associated with lower rates of cardiac death, MI, stent, and revascularization, and a reduction in all-cause mortality. But there was more major bleeding in the first 6 months after PCI. For the bleeding events, they looked at the 2012 Danish registry and the 2012 Horizons AMI analysis, both of which saw more major bleeding in the triple therapy group versus double therapy. So that leads us to the final recommendation. So in patients with AFib at increased risk of stroke and have undergone PCI with stenting for ACS, double therapy with the P2Y12 inhibitor and dose-adjusted VKA is reasonable to reduce the risk of bleeding as compared with triple therapy. So how long? This will lead us into the ISAR triple trial. So the objective of this trial was to determine if patients with a drug-eluting stent would benefit from a reduction in duration of triple therapy from 6 months to 6 weeks. The researchers chose their timeframes for triple therapy based on the fact that dual antiplatelet therapy is generally recommended for at least 4 weeks for bare metal stents and 6 months for a drug-eluting stent. In this trial, 6 weeks of dual antiplatelet therapy was chosen to provide patients receiving drug-eluting stent with a DAPT duration close to that required in patients receiving bare metal stents, under the assumption that further protection from stent thrombosis might also be offered because of the presence of oral anticoagulation. So patients were randomly assigned to warfarin, clopidogrel, and aspirin for 6 months, or warfarin, clopidogrel, and aspirin for 6 weeks. They were followed for 9 months post-initiation of triple therapy. At 9 months, aspirin was being used in 96% of the patients, and oral anticoagulation was being used in 88.5% of the patients. Non-compliance with the prescribed clopidogrel regimen was approximately 25% at the 6-month follow-up. So the primary composite endpoint was death, MI, stent thrombosis, stroke, and major bleeding. And there was not statistically significant difference in the primary composite endpoint in ischemic complications, nor was there a significant difference in TIMI, minor, or major bleeding. INR values were within the therapeutic range about roughly 60% of the time, with no difference between the two groups. So the authors concluded that 6 weeks of triple therapy compared with 6 months of triple therapy was not superior in regard to net clinical outcomes. Neither was there a positive to one group over the other in terms of ischemia or bleeding. So they concluded that the optimal duration of triple therapy was not established. Based off this trial, these 2 conclusions that the 2019 AGHP article made concerning the ISAR triple trial. I will note the trial was not specifically powered to detect differences in the individual components of the primary endpoint, and the trial did not have enough bleeding events to power superiority. So I think we have to use caution when interpreting this trial against assuming non-inferiority from an underpowered trial that was designed to initially show superiority. And so these are the risks from the white papers. They weren't changed in the update. They're from the original 2016 version, but this is something that you could use to decide, is my patient more at an increased risk of an ischemic event or stent thrombosis, or do they lean more towards an increased bleeding risk? And so that 2018 paper provides this treatment algorithm. So in selected patients considered at high ischemic or thrombotic and low bleeding risk, this expert consensus finds it reasonable to continue with aspirin therapy, so triple therapy, for a limited period of time after hospital discharge. This consensus also states that it is reasonable to extend aspirin therapy up to 1 month after PCI and rarely beyond this time. If the patient was on a reduced dose anticoagulation based off of a trial that we'll talk about in a few moments, it would be reasonable to change back to the normal anticoagulant dose. Additionally, continuation with a single antiplatelet therapy in addition to oral anticoagulation may be reasonable for patients with high ischemic, thrombotic, and low bleeding risk. The choice of single antiplatelet therapy to use after 1 year, aspirin or clopidogrel, is at the discretion of the treating physician. And so the trials that we've looked at so far have shown that a strategy of double antithrombotic therapy consisting of oral anticoagulation in combination with a P2Y12 without aspirin started at the time of hospital discharge is associated with significantly lower risk of bleeding complications without an apparent trade-off in thrombotic events when it's compared to triple therapy. And so in patients in whom double therapy is considered, aspirin is recommended by the white papers in the peri-PCI phase. And so in summary, if triple therapy is prescribed for patients with AFib at an increased risk of stroke who have undergone PCI with stenting for ACS, a transition to double therapy at 4 to 6 weeks could be considered. So which anticoagulant do we use? We have 3 main trials that we can look at: Pioneer, AF, Redual PCI, and the Augustus trial. We'll start with Pioneer AF. So the objective of this trial was to determine if low dose or very low dose rivaroxaban could be safely used with a P2Y12 inhibitor as opposed to standard triple therapy in patients with AFib and PCI and stent placement. So the primary safety endpoint was the composite of major or minor bleeding, and the efficacy endpoint was frequency of MACE. So this is kind of the overall breakdown. It's a very different dosing than what was used in the Rocket AF trial. So patients in group 1 were assigned to receive rivaroxaban at a dose of 15 milligrams once daily, different from our 20 milligrams in standard AFib, okay? Or a dose of 10 milligrams once daily if they had moderate renal impairment for a creatinine clearance of 30 to 50, plus a P2Y12 inhibitor for 12 months. Aspirin could be administered up to 24 hours before the first dose of the trial drugs, but after that, aspirin at all doses was to be withheld after randomization. Patients in group 2 were assigned to receive rivaroxaban at a dose of 2.5 milligrams twice a day, plus dual antiplatelet therapy with low-dose aspirin and a P2Y12 inhibitor for the prescribed duration of 1, 6, or 12 months. The duration of 1, 6, or 12 months was not randomized, and it was at the discretion of the physician. Participants who received the treatment for 1 or 6 months then received rivaroxaban at a dose of 15 milligrams once daily or the reduced 10 milligram dose, plus single antiplatelet therapy with either, just with low-dose aspirin for the remainder of 12 months. And lastly, patients in group 3 were assigned to receive warfarin once daily, plus low-dose aspirin and a P2Y12 inhibitor, again, for 1, 6, or 12 months at the discretion of the physician. Participants who received the treatment for 1 or 6 months then received warfarin once a day, plus single antiplatelet therapy with low-dose aspirin for the remainder of the 12 months. I wanted to tell you guys the average time in range for therapeutic INR of warfarin was similar to what we saw in the previous trial at 64%. And for the primary safety endpoint, we can see here they looked at group 1 versus group 3, which was statistically significant, and then group 2 versus group 3, which we also saw a statistically significant difference in the risk of major or minor bleeding. I will note that this trial was not adequately powered to detect a significant difference in the efficacy endpoint of MACE events. However, investigators reported this information, and they did note that it would take about 40,000 patients to adequately power a trial for these MACE endpoints. So this trial was about 2,000, so that's probably not going to happen. The researchers' conclusions for this trial. So among patients who underwent PCI, administration of either rivaroxaban 15 milligrams once daily plus a P2Y12 inhibitor for 12 months, or rivaroxaban 2.5 milligrams twice daily plus dual antiplatelet therapy for 1, 6, or 12 months was associated with lower rate of significant bleeding than with standard therapy with a vitamin K antagonist plus dual antiplatelet therapy for 1, 6, or 12 months. The trial did not address the ideal duration of therapy, as the duration was not randomized and was at the discretion of the clinician based on risk factors. So the next trial concerning the use of DOACs in the situation where triple therapy may be warranted used dabigatran. So the purpose of the REDUAL PCI trial was to compare the use of 2 regimens of dual antithrombotic therapy that included dabigatran with the use of triple antithrombotic therapy that included warfarin among patients with AFib who had undergone a PCI. So there was about 3,000 patients in this trial. Patients had to have AFib with PCI and stent, and the primary endpoint was, again, the safety endpoint that looked at first major or clinically relevant non-major bleeding event. And the efficacy endpoint was, again, the composite of thromboembolic events. So these are the 3 groups of patients who were randomized in a 1-to-1-to-1 fashion. The first group was the standard triple therapy with warfarin, clopidogrel, or ticagrelor plus aspirin. The aspirin was discontinued after 1 month in bare metal stents and 3 months in drug-eluting stents. Group 2 was a dose of dabigatran we don't see in the US, and I think this trial was done in Japan, and they basically included this because if you're an elderly patient, meaning greater than 80 or 70 years old in Japan, it's recommended that you take 110 milligram BID dose for AFib. So that's why they included this dosing strategy. And then group 3 was the traditional dabigatran 150 milligrams BID dose and either clopidogrel or ticagrelor. And the study had a mean follow-up of 14 months. So these outcomes were looking at non-inferiority. The dotted line there is the dual therapy with dabigatran, and the top graph is the reduced dose of dabigatran, and the bottom graph is the full dose. And you can see that there was a statistically significant difference with both groups. So concerning the secondary composite endpoint of thromboembolic events, there was not a difference between the 2 groups. However, the outcome was statistically significant for what it was looking for at non-inferiority. So from this trial, the researchers concluded 2 things. Comparing the dabigatran dual therapy groups to triple therapy with warfarin group, 1, the risk of major or clinically relevant non-major bleeding events was significantly lower. And 2, is non-inferior with respect to composite efficacy endpoint of thrombotic events, death, or unplanned revascularization. Some limitations: this trial was, again, not powered for individual components of efficacy, and we don't use that dose here in the United States. So you've probably already recognized a couple of problems with these trials. So both of these trials compared either lower than approved doses of new oral anticoagulants, DOACs, with full dose vitamin K antagonists. They target an INR 2 to 3, or strategies of double therapy, one of the new DOACs plus a P2Y12 inhibitor with traditional therapy, oral anticoagulation plus P2Y12 inhibitor plus aspirin. So given their designs, it's impossible to determine whether the lower risk of bleeding that was seen in the new oral agent groups was due to one of three different things. Was it the use of the new agent, the DOAC, the reduced dose of the DOAC as compared to normal AFib dosing, or was it the discontinuation of aspirin? So we have a possible solution, Augustus. There's Caesar Augustus with some of my co-residents when I was PGY1. Okay, so Augustus, this is the third and final trial that we're going to look at concerning anticoagulation. This is also one of the most recent ones. So concerning the three most commonly used DOACs, it involves apixaban. So the objective of the Augustus trial was to assess the safety and efficacy of apixaban as compared with warfarin, and of low-dose aspirin as compared with placebo, along with the P2Y12 inhibitor therapy for 6 months in patients with AFib and a recent ACS. It is a journey. I'm going to tell you the different patient groups in a minute. So this was the largest of the three trials. There was a little over 4,600 patients randomized. It was an older population, mostly male, mostly white, and patients had to have AFib and undergoing PCI, as we've seen in other studies. And similar to the Riedel PCI trial, the primary safety endpoint was first major clinically relevant non-major bleeding event. And again, we had a composite efficacy endpoint. So this is a 2x2 factorial design, and it's efficient in that it permits the separate evaluation of 2 or more interventions within one single trial. And that is the way these patients were randomized in a 2x2 factorial design. First, patients were randomized to either of the 2 anticoagulants, apixaban or warfarin. AFib dosing was used in the apixaban patients, so no strange dosing for this trial. If they met the criteria, serum creatinine greater than 1.5, age greater than 80, or weight less than 60, if they have 2 of 3 of those criteria, they got the reduced dose. Patients were also randomized to either aspirin, so putting them on DAPT, or placebo, meaning they were on single antiplatelet therapy. I'll note that clopidogrel was used in 92% of these patients. So this slide looks at the primary outcome looking at the 2 different randomizations, apixaban versus warfarin, and on the bottom, aspirin versus placebo. The primary outcome occurred in 10.5% in the apixaban group and 14.7% in the warfarin group. This was a statistically significant difference that was not only statistically significant for non-inferiority, but also for superiority. Taking the hazard ratio, you can calculate a number needed to treat of 24 patients to prevent 1 bleeding event if the patient is receiving apixaban versus warfarin. Concerning the aspirin versus placebo, bleeding outcome occurred in 9% in the placebo group and 16.1% in the aspirin group. Again, this was statistically significant difference as the patients on DAPT had this higher incidence of bleeding. Taking the hazard ratio, you can calculate a number needed to harm of 14 patients. So for every 14 patients that are on aspirin in the setting of dual antiplatelet therapy, 1 patient might have a bleeding event. And so really what we want to know from this trial is highlighted on this slide. This graph shows the 4 different groups and the incidence of the primary safety outcome. As you can see in the top purple line, the highest incidence of bleeding events occurred in the warfarin and dual antiplatelet therapy groups, the lowest occurring in the apixaban and single antiplatelet therapy group. If you're going to go with the triple therapy route for a time being, try to do it with a DOAC if possible. Now, switching gears over to the efficacy endpoint, specifically to the combined endpoint of death and hospitalizations, there was a slight statistically, I shouldn't say slight, there was a statistically significant difference between apixaban and warfarin, with apixaban having a lower incidence. However, there was not a statistically significant difference between aspirin and placebo. And so concerning the ischemic events combined with death or just stent thrombosis, there was not statistically significant difference between apixaban or warfarin. And so when looking at the aspirin versus placebo, there was less incidence of stent thrombosis with aspirin versus placebo, but again, it wasn't significant. Thus, when clinicians consider aspirin as a component of antithrombotic therapy after PCI in patients with AFib, a potential small absolute decrease in the risk of coronary ischemic events needs to be weighed against the larger absolute increase in the risk of clinically significant bleeding. The risk of coronary thrombotic events was higher in the placebo group than in the aspirin group, and the incidence of stent thrombosis was nearly twice as high in the placebo group. It would be incorrect to interpret the lack of significant p-value as no difference, because although the Augustus trial was a large trial evaluating this question, it was still substantially underpowered for coronary ischemic events. And so the consistency of the trends towards more thrombotic events in the placebo group than in the aspirin group strongly suggests that there may very well have been a significant difference if more patients had been enrolled in this trial. So when clinicians consider aspirin as a component of antithrombotic therapy after PCI in patients with AFib, a potential small absolute decrease in the risk has to be weighed against that bleeding risk. And the highest risk for coronary ischemic events is in the days and weeks after the event. So patients were not enrolled in this trial until a mean of 1 week and up to 2 weeks after the index event of PCI. And so that during that period, the patients could receive aspirin. So that is one of the limitations of this trial. And so the effective early withdrawal of aspirin still kind of remains uncertain. And so caution is advised in those first few weeks following PCI. And so in summary, patients, the guidelines say the patients with AFib at increased risk of stroke who have undergone PCI with stenting for ACS, double therapy with P2Y12 inhibitors and low-dose rivaroxaban or dabigatran is reasonable to reduce the risk of bleeding as compared with triple therapy, based off some of those trials that we saw. Of course, was a 2019 focus update, and the Augustus trial was in 2019, so that's why they don't specifically mention apixaban. Lastly, which antiplatelet? So going back to that 2018 white paper, there's not many trials to look at this question as compared to the other questions. However, this paper does make some recommendations. I will caution it is not representative of a guideline because it's not endorsed by Cardiovascular Society. So this is a North American expert consensus group. And concerning the newer P2Y12 inhibitors, based off the Triton-TIMI trial and the Plato trial that we talked about earlier, since clopidogrel has a lower bleeding risk, they recommend clopidogrel. So concerning prasugrel, there was this 2013 trial. And the purpose of the trial was to evaluate whether prasugrel may serve as an alternative to clopidogrel in patients with triple therapy. So it was kind of a small trial, just under 400 patients who underwent PCI with a drug-eluting stent and also had an indication for oral anticoagulation. And they were treated with a 6-month regimen of aspirin, oral anticoagulation, and either clopidogrel or prasugrel. Primary endpoint, major or minor bleeding. And as far as the results from this trial, only 21 patients received prasugrel instead of clopidogrel. So I don't know what the advantage this is, but the authors concluded that these findings suggest that substitution of prasugrel for clopidogrel in patients needing triple therapy does increase the risk of major bleeding. However, specific randomized trials are really needed to define this newer prasugrel agents in this type of setting. And so final recommendations from that 2018 white paper: tailor P2Y12 inhibitor therapy according to patient-specific risk. Lower risk of bleeding complications with clopidogrel makes it the P2Y12 inhibitor of choice. And among patients at high ischemic or thrombotic risk and low bleeding risk, ticagrelor may represent a reasonable treatment option. However, these are low recommendations. The 2019 guidelines, their preference and their recommendation on P2Y12 inhibitors is to choose clopidogrel in preference to prasugrel. And so that was a lot. And just in summary, assessing patients' ischemic and bleeding risk and using validated risk predictors such as CHADS-VASc and HAS blood scores. And if you want to, look at those precise DAPT or DAPT scoring tools, should be a case-by-case basis for each patient. Keeping triple therapy duration as short as possible with the consideration of dual antithrombotic therapy after PCI. It is reasonable to extend low-dose aspirin therapy for a limited time period. And DOACs are preferred over VKA if possible. Use clopidogrel as the P2Y12 inhibitor of choice. Keep aspirin at low dose, 81 milligrams. And again, I don't know that I really answered a lot of these questions because it's such a gray area and it's still gray. It's never going to be one size fits all, right? It's always going to be this clinical conundrum of ischemic events, bleeding risk. And so just hopefully I gave you enough tools and information to make those decisions for your patients. So our knowledge check. Back to our patient. They made the decision to start PK on triple therapy with clopidogrel 75 every day and aspirin 81 milligrams for 4 weeks. He currently takes warfarin 5 milligrams a day at home for his AFib. He wants to stay on warfarin because he really loves his ambulatory care pharmacist, but he isn't totally opposed to changing medications. What would be an appropriate anticoagulant regimen for our patient to be discharged on? Rivaroxaban 2.5 once a day, continue with warfarin, apixaban 5 BID, or we don't need anticoagulation because we're adding the clopidogrel. C, yay. Yes, correct answer. Okay, so on rounds, they want to switch our patient from clopidogrel to a different P2Y12 inhibitor because they want to prevent stent thrombosis. So now they want to discharge him on aspirin, apixaban, and prasugrel. What do you think about this new regimen? This plan is great. It will prevent stent thrombosis. There is more data in triple therapy with clopidogrel. We should stick with that. Or prasugrel would lead to greater stent thrombosis risk. Don't do it. And maybe the patient doesn't need a P2Y12 inhibitor. Yes, got it right. Okay, and I like to end all of my CEs with a quote. And if you know me, you know I love Taylor. So in her NYU commencement speech, I really liked what she said. She said, "I'm a big advocate for not hiding your enthusiasm for things. It seems to me that there is false stigma around eagerness in our culture of unbothered ambivalence. Never be ashamed of trying. Effortlessness is a myth." And I thought that that was a good way to start off this new residency year and our first CE. So with that, I'll take any questions and I hope you guys learned something today. Great.
First of all, this was an excellent review of a very dense topic. So thank you for that.
You're welcome. It was a journey.
I'm going to relate this back to Emily and I'll for a minute. So oftentimes we'll have patients come in who have had an MI, PCI with stent placement within the last 4 weeks who fall and now have this head. And our strategy in general is to resume them on aspirin as quick as possible, as long as we have determined that their head bleed is not propagated any further. Is that a reasonable approach bleed thrombosis versus combination of a hip?
Yes, I would say so. As this often what we, I trained at a VA, so we had little old men that would come in on all these different agents, hitting their head, bumping all around, and so there is a good paper. I can find it for you. You've probably seen it, but basically, I think that you would have to fall and like hit your head 100 and something times a year, okay, like to really outweigh the risk of intracranial hemorrhage versus thrombosis. So I'm always a big advocate is as long as the patient is stable and you have the scans or MRIs to back up that bleed is stopped and not spreading, there's no conversion of resuming their agents, especially in the setting of a recent stent placement and AFib. Yeah, I definitely think that that could be a situation where, if you were originally planning on doing like triple therapy in that patient for 3 months, right? You may say, whoa, like let's like back up and rethink. Like maybe this is a good patient that only needs triple therapy for 1 month. And so maybe we back off to their oral anticoagulation and a single antiplatelet therapy. And if they feel more comfortable using, just the P2Y12 inhibitor, that might be an option. Especially because now we do have all of this new evidence suggesting that aspirin in that situation may not be providing much benefit.
Yeah, I think that's where I'm a little bit like after
Yeah.
Is it even worth it, or do we just wait the 7 to 10 days?
Yeah.
Nothing.
I think.
Right.
Yeah, I would imagine that your ICU dogs would be a little hard pressed to want to get right back in there with, especially a P2Y12 inhibitor. Yeah, that's also an option. Someone should do that trial. I would have to look. I didn't actually look at Kangaroo in that setting. Yeah. No. No one's gonna like that. Any other questions? All right, well, it's 2 o'clock on the dot. So I didn't give you any time. Oh, I have your CE. This is the code that you may redeem for credit. Can you not see it? Oh, man. Let's see. There it is. Sorry. I can see it. Listen, she's just being a good friend. She's just letting people borrow.
It wasn't all on her jet. Other people rent that jet.
Like, people rent that jet.
Hey.